I think we have a great showing already, so I think more people will show up, but we can go ahead and get started. Again, hi and welcome everyone to another edition of UCSF Cardiology Grand Rounds. My name is James Al-Assad. I'm the third year Chief Fellow, and this week we're very fortunate to have Dr. Erin Michos presenting on obesity management for cardiovascular disease prevention. And her talk is also titled New Tools in a New Era, which is a topic I'm very, very excited about. To provide some background about Dr. Erin Michos, she is an associate professor of medicine within the Division of Cardiology at Johns Hopkins School of Medicine, with joint appointment in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. She is the Director of Women's Cardiovascular Health Research and the Associate Director of Preventive Cardiology within the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. She is an internationally known leader in women's cardiovascular health, lipids, and preventive cardiology. She has co-authored hundreds of manuscripts in peer-reviewed journals and many book chapters. She just recently published a JAHA review on the role of glucagon-like peptide 1 receptor agonists in achieving weight loss and improving cardiovascular outcomes. Obviously very pertinent for this topic. So again, with that, I'll leave it to Dr. Michos, but I'm very fortunate to have you. Thanks again for coming.
Thank you so much for inviting me. So, when the LEADER trial came out in like 2016, I jumped on GLP-1 therapy early for my patients, and some of my colleagues initially were a little reluctant to come along. They were, saying, we don't treat diabetes, have their endocrinologist start it. And I kept saying, but we're cardiologists, we treat cardiovascular risk, and these are cardiovascular prevention agents. So now I'm going to say the same thing about obesity management. I still hear maybe that cardiologists maybe don't feel comfortable treating obesity, or they don't think it's in their purview, but this is our wheelhouse. We do address cardiovascular risk, and hopefully I can convince some of you out there why we need to get into the space. And the good news is we have more tools than ever before to help our patients. Let's see here. These are my disclosures. So I think you're all aware that we have a major problem with obesity, a major health problem. 71% of US adults are now overweight or obese. A similar prevalence in males and females about obesity, about 41%. And, in charting and things, I always try to use the different classes of obesity: class 1, BMI 30 to 35, class 2, 35 to 40, and class 3, above 40. I try to delete any wording of morbid obesity out of the chart. I think that's really stigmatizing. We don't say someone has morbid cancer, or, so I think words matter. And so I don't like using the word morbid obesity. I'm also trying not to use the word obese as an adjective. People are more than their disease. So instead of saying obese adults, adults with obesity, adults with overweight or obesity, because, again, people are not defined by their disease. So we have a huge problem, as mentioned. This is a US map, even from a couple of years ago. It's probably gotten worse since then, with every state in the United States has more than 20% of adults with obesity. So, BMI above 30, and 1 in 5 adults in every state. In some of the states here, you see that the prevalence approaches 50%, with close to 1 in 2 adults with obesity. And worldwide, if you look at a BMI above 25, they're estimated by the year 2035 that 51% of adults worldwide will have overweight or obesity, with nearly a quarter meeting obesity criteria with a BMI above 30, with an estimated global cost of $4.3 trillion. So this is a huge problem. And we know it's also associated with reduced life years and quality of life, particularly when have a younger onset. In younger adults with obesity, they may have 9 years shorter lifespan and 19 years shorter of quality of life, because of acquiring morbid conditions related to obesity. And we know the association of obesity with many of the cardiovascular complications. That's why we're in this space between coronary disease, stroke, atrial fibrillation, heart failure, particularly heart failure, preserved ejection fraction, and the associated comorbidities of diabetes, sleep apnea, gout, and numerous other health problems, fatty liver disease, osteoarthritis, and cancer. So this is a really important health issue broadly beyond cardiovascular disease. And looking at BMI, which is not the best perhaps measure of adiposity, but a reasonable surrogate in populations. We see that as BMI, there's a J-shaped relationship with both, underweight, which may be a marker of frailty and other diseases, as well as overweight being associated with increased mortality. And though in this large UK data set, over 3.6 million adults who are non-smokers, so not having confounding by smoking, we see a linear relationship above a BMI of 25 with increased risk of death. Obesity is associated with all sorts of cardiovascular complications, but it seems to have the strongest relationship with heart failure, more so than coronary disease, almost a fourfold increased risk. Now, there's been some discussion about, can someone be metabolically healthy obese, defined as having, elevated BMI, but no dyslipidemia, no hypertension, no diabetes. But in this large health care registry, these adults who met the criteria for metabolically healthy obesity still had over follow-up, a 49% increased risk of coronary disease, a 7% increased risk of stroke, and nearly twofold increased risk of heart failure compared to normal weight metabolically healthy. So I think there's probably no such thing as metabolically healthy obesity. It's on a spectrum of metabolic dysfunction. And just like we think about pack years of smoking and cholesterol years, where it's not, just the magnitude of elevation, but the duration of exposure, the same thing with obesity, with BMI years. This is one of my studies from the multi-ethnic study of atherosclerosis, MESA. And, even after we accounted for the participants' current weight and adjusted for their current risk factors, just the history of more years of being overweight, for every, having an elevated BMI from age 20 or age 40, that was still associated, this duration, with increased risk of heart failure, even after we accounted for their current weight. So we want to try to, unfortunately, obesity is also becoming more prevalent in younger adults, and we want to really shift prevention earlier in life. So a metabolic endocrinologist professor in the United Kingdom had published this review of he called this analogy, the soggy bathroom carpet model of overnutrition related metabolic diseases, sort of like this analogy. I guess in the United Kingdom, they have carpets in their bathrooms. I don't know. I think that's kind of gross. But in this analogy, he was, talking about the role of adipose tissue is for storage of energy. Adipocytes store triglycerides in the form of energy, and sort of in a healthier state, you have sort of a match with energy intake, and then you have some storage for when you need energy, and then there's energy expenditure that's proportional, and so the carpet stays dry. But in the obese insulin resistant state, there's both increased, energy intake, and there's also decreased energy expenditure. And as I'll talk about this is far more complicated than calories in, calories out. This is regulated by a lot of things. And so there may be a lot of things outside of the patient's control about why the drain is not working. But essentially the bathtub overflows and you have adipose deposition in multiple organs, the liver, the heart, other organs. And this leads to the very soggy bathroom carpet. And then we know that some individuals, particularly of those of Asian descent, actually have evidence of cardiometabolic consequences at a lower BMI. And it may be that they have a smaller bathtub, a limited adipose storage capacity, so they overflow to the soggy carpet, at a lower BMI. So adipose tissue is not just a passive reservoir of fat, of energy storage. It's actually an active endocrine organ that releases a lot of factors, cytokines, and these adipokine hormones, leptin, adiponectin, IL-6, TNF alpha, that influence not only someone's body weight homeostasis, but also insulin resistance, diabetes, lipid levels, coagulation, fibrolysis, inflammation, and atherosclerosis. And so these are a lot of the drivers of the downstream complications. And so essentially, obesity is a low grade inflammatory state that leads to these downstream cardiometabolic and cardiovascular complications. Now, it is a class 1 indication with both US and European guidelines that, weight loss is recommended in individuals with overweight and obesity for the purposes of cardiovascular risk reduction. So what's a clinically meaningful weight loss? Well, in trials, we want a weight loss at least 5% is considered clinically meaningful. If we can at least achieve 5% in weight loss, there starts to be some improvement in some of the cardiometabolic parameters. But likely you need greater weight loss to achieve some of the more significant benefits, such as reduction in cardiovascular events and remission of diabetes. Now, in the look ahead trial, so this was a trial that enrolled patients with diabetes, comparing an intensive lifestyle intervention compared to usual care. The overall trial was unfortunately null. But if you looked at, that's because unfortunately they weren't able to really achieve overall, significant amounts of weight loss. But if you look at those that were able to achieve a large loss, more than 10% of weight loss, those individuals did have a 21% reduction in major cardiovascular events. So more data showing that really significant weight loss in those that are overweight and obese can translate to cardiovascular outcome reduction. Now, I think we did our patients a lot of disservice when we start thinking you just need to exercise more and eat less. It's just all calories in, calories out. Unfortunately, it's not that simple. Obesity is a complex chronic disease influenced by genetic, hormonal, neural, environmental, and social factors. And 70 to 80% of our BMI is determined by our genes. There's certainly a gene environment interaction. So having genetic susceptibility, and then we live in a very obesogenic environment with the kind of processed foods and excess calories that are available, and the way our jobs have changed in terms of being more sedentary at the computers and how we commute to work in our cars. And with that environment interaction, it's led to this explosion of obesity. But the brain, as I'm going to show you, regulates a lot of one's weight set point. So it's really about chemistry, not character. Obesity is really a brain-related disorder. It's a brain disease. And the hypothalamus plays an important role in regulating body weight by balancing intake of food, energy expenditure, and body fat. And so this can get disrupted by different biological environment factors. And once disrupted, feelings of hunger and satiety can be affected. And the body resets at the highest, tries to hold on to the highest fat mass. And so there can be tremendous drivers for hunger, and unfortunately, that's why weight regain is more often the norm after significant weight loss. So this is some of the data showing this, that 80% of people who lose 5% of their weight regain it over 5 years. So this is really challenging chronic disease to treat. Data from 14 lifestyle interventions of reduced calorie diets do show that if you closely monitor somebody, you can achieve significant weight reduction, but most individuals regain a large proportion of their initial weight within a few years. And we see this even with shows like The Biggest Loser, where they're in this tense controlled environment, they lose a lot of weight, and then when they go back to their own environment, unfortunately the majority of those contestants regain their weight. And so obesity really is a chronic disease, but it doesn't get the same level of attention as other chronic diseases. And there's often a lot of unfair stigma that limit our effectiveness in delivering preventive interventions. There's a biopsychosocial model for obesity. Again, there's biological factors, social factors, psychological factors that all drive one's weight set point. And there can be tremendous bias, even bias by other healthcare clinicians towards patients. Patients have their own internalized bias, and this can lead to suboptimal outcomes. In fact, patients themselves have, after years of sort of exposure in society, often have internalized weight bias, which can affect one's mental health, lead to psychological effects. And there has been some studies showing that, in combination with other therapies, lifestyle and pharmacologic, that cognitive therapy support can help with better response. So, this can be a sensitive subject. And so how do you approach it with your patients? And one is to really get their permission to talk about their weight in a non-judgmental, neutral, non-stigmatizing weight. And some have proposed using the 5A approach, just like we would approach somebody for tobacco cessation. Ask them if you can discuss their weight and really focus on the health impact. So focus on that rather than, the sort of their personal choices. Assess, health status and its complications. Advising on treatment options based on their severity of their metabolic disease. Coming to a shared decision making about the treatment plan and weight loss goals, and then assisting them continually reassessing the process with reassessment of goals and treatment options. Now I'm going to talk about all the sort of the new exciting therapies that are all sort of out there, but just so you know the landscape of some of the FDA approved older anti-obesity medications. For some of the older ones, weight loss is about 5 to 10% range over 3 to 6 months. There's quite variability from person to person. Even with the older medicines, sometimes insurance doesn't pay for them. We have that issue with some of the newer therapies. So cost can be an issue. And medicines only work as long as a person takes them. And so these are not cures, these are treatments. And so a person needs to be open to long-term use. And even when I'm going to talk about the GLP-1 therapies, we'll talk about weight regain upon cessation. And really, when you embark down this pathway, you have to talk to patients about the long-term approach, that these are not quick fixes. But, you can certainly give a trial for 3 to 4 months to see how a person's responding to a therapy and then decide on long-term use. So I'm going to talk about some of these agents, but here's just putting through this on the scale. So lifestyle interventions often are in the range of 5 to 7%. The older anti-obesity medications can maybe get up to 10% weight loss. Semaglutide, about 12% weight loss. Tirzepatide and other dual agonists, about 18% weight loss. Triple agonists, some of the new kids out, in the 22 to 24% range. Of course, there's still metabolic surgery, bariatric surgery as an option for patients, and that can achieve much more significant weight loss in the range of 30 to 35%. And some of our patients who have significantly elevated BMI, it's a combination of surgery plus medications. So this slide was already, we have more newer therapy, but the older therapies I'll talk to have about a 5 to 10% placebo-corrected weight change. Liraglutide is a GLP-1, but the weight loss here was more modest, only a 6% placebo-corrected change, where the newer therapies were getting from 12% up to 24% placebo-corrected weight change, approaching metabolic surgery. So I don't prescribe the older medicines myself, but just so you're aware of the landscape, your patients may be on them if they're in a weight management clinic. There's orlistat. This is a pancreatic lipase inhibitor, works by reducing absorption of dietary fats. It's been FDA approved since 1999. It has about a placebo-corrected change in the order around 6% or so. It still has a cost. It's the safest option because it doesn't get systemically absorbed. But weight loss on average was pretty modest, only about 3 kilos. And unfortunately, by inhibiting dietary fats, you can imagine that there is flatulence and fatty stools, and these unfavorable GI side effects really limit its usefulness in clinical practice. Then there's phentermine alone. So I think you are familiar with the saga about fen-phen. The other fen fenfluramine was the one that really caused the problem, but it was in combination with phentermine. It was withdrawn in 1997 due to causing pulmonary hypertension and valve disease. And it was really the fenfluramine component that caused those issues because that was a serotonin releasing agent. You can get phentermine alone, and it is the cheapest option, like $15 to $25 a month. It works by increasing norepi in the brain. Again, weight loss alone is modest, 3 to 7%. But it can have some side effects that us as cardiologists don't like, such as increased heart rate, increased blood pressure. So there has been concerns about cardiovascular risk, and that's why FDA only approved it for only 3 months use. Now, in a EMR data set where they looked at patients, over 13,000 patients that have been prescribed phentermine, and they followed them for 3 years, they didn't see a signal for excess events. But again, this real world data, this is likely selection bias. Patients at elevated cardiovascular risk likely were not prescribed this. The Endocrine Society says you could use longer than 3 months if someone doesn't have serious cardiovascular disease or substance abuse, if they didn't demonstrate that they had any impact on their blood pressure or pulse with use, and if it actually worked, if it actually gave them more than 5% weight loss, then maybe they can continue on longer. Now, phentermine also comes in combination with topiramate. This is Quisma. This combination is greater efficacy with fewer side effects. It can be in the range of up to $200 a month. It does have some side effects, dry mouth, dizziness, insomnia, irritability. You don't want to use it in women attempting pregnancy. You can get up to 10% weight loss. So this is one of the more effective oral older options. The topiramate may help with patients that have migraines or neuropathy. Then there is naltrexone bupropion, or it goes by Contrave. This costs about $600 a month if your insurance doesn't cover it. Just like we're familiar with bupropion, you can have lowering the seizure threshold, but it may be helpful in patients that have issues with needing smoking cessation or other cravings or have depression because of the bupropion in it. There are some medicines, older medicines that are used off label for weight management. Like some people use bupropion alone. It doesn't have an FDA indication for weight loss, but might have some modest weight loss effects, 5 to 7%. Metformin doesn't have an FDA label for weight loss, but may confer 3 to 4% weight loss in persons who don't have diabetes. SGLT2 inhibitors also don't have an indication for weight loss, but may confer a more modest 2 to 4% weight loss. And of course, if patients have heart failure or diabetes or kidney disease or have an indication for SGLT2 inhibitor, that would be a good option for them. Now, bariatric surgery, again, the literature discusses more evidence that, if you can significantly reduce weight in persons with overweight and obesity, you can improve cardiovascular outcomes. And in this meta-analysis of patients that underwent bariatric surgery, we did see significant reductions in cardiovascular outcomes, including a 45% reduction in all-cause mortality. I'm not going to get too much into metabolic surgery, but it's still an option out there for patients. And they've lowered some of the thresholds where metabolic surgery can be recommended for patients with BMIs above 35, or if their BMI is above 30 and they have other health conditions like diabetes. If they've not been able to achieve their weight goals through other non-surgical methods. So moving on to the GLP-1. So, we've already had these out for management of diabetes and cardiovascular outcome reductions. They're thought to help with glucose metabolism by increasing insulin secretion, increasing beta cell function, but also has benefits which likely contribute to their weight loss in that they decrease gastric emptying. So people feel full. So it increases satiety. They work directly in the brain. They decrease appetite, increase satiety, increase energy expenditure. They have other benefits that could be their purported role of why we see cardiovascular benefit, that they may have some cardioprotective effects despite having a very slight increase in heart rate. They seem to help the kidney with reduction in microalbuminuria, and they're being studied right now in a dedicated kidney outcome trial called FLOW for their kidney benefits. They also have been looked at for fatty liver disease. They seem to help decrease liver fat production. And so these are from one of my review articles, but these are sort of the effects why we think that there's cardiovascular protection. We certainly see cardiovascular protection in persons with type 2 diabetes, that, through blood pressure lowering, glycemic lowering, weight loss, having anti-inflammatory effects, perhaps anti-atherosclerotic effects, and natriuresis and diuresis. All right, so moving on to their role in weight management. So the STEP series evaluated semaglutide in which was already has an FDA approval for persons with diabetes for cardiovascular risk reduction, but then was evaluated for patients who had overweight and obesity who did not have diabetes. So in the STEP 1 trial, they had to have a BMI above 30 or above 27 with at least one weight-related comorbidity. They were followed for 68 weeks. And titrate up to the highest dose of 2.4, we see a 12% reduction, placebo-corrected reduction in weight, which translates to 28 pounds. So that's a lot. If you look at our threshold of achieving clinically meaningful weight loss, which is defined above 5% weight loss, 92% of patients on semaglutide versus 33% of patients on placebo were able to achieve this goal. So you can see there's some variability, but some patients were even able to achieve, more than 20% weight loss. Now, the next sort of class of in this agents were the dual agonists. So tirzepatide is a dual agonist. It's an agonist of GIP and GLP-1. So it's not a combination drug. It's a single molecule that is an agonist for both of those receptors. It's also been approved for patients with diabetes. It had more effective A1C lowering in persons with diabetes than semaglutide alone. And then was studied in the SURMONT trial in persons with overweight and obesity, but without diabetes. And this dual agonist conferred a placebo-corrected, 18% reduction in weight, which translates to 52 pounds. So we're really getting here into significant weight loss. And again, these are all the different doses. They try to titrate up to the maximal dose of 15 milligrams per week. And we see with the maximum doses that you also get about 91% of patients at least achieve more than 5% weight loss compared to 35% with placebo. Now, this is not a magic bullet. This is not a cure. This is part of a treatment to manage a chronic disease. And one thing that we do know and we see is that if you stop therapy, patients regain. And so this is with the STEP trial with semaglutide. And, this is where their weight was at 68 weeks. And then off therapy, open labels or off treatment extension to 1 year, continue to show safety. But patients gained about 2/3 of their initial weight. So they didn't overcorrect. They didn't go back higher than baseline, but they had significant weight regain. And so this is a really important thing to talk to your patients about, to set realistic expectations. Because if you don't have this discussion, you're really doing your patients a disservice and can lead to a lot of hurt, when they get to their weight goal and then they can stop therapy and then they regain it back. But, the same thing, having expectations. If someone has hypertension and you put them on a blood pressure medicine and you stop the blood pressure medicine, their blood pressure is going to go back up. And, if someone has high cholesterol and you put them on a statin, you would never tell them that, oh, we're going to cure your cholesterol. As soon as they stop the statin, their cholesterol is going to go back up. So it's the same thing. It's part of chronic therapy, but there's a lot of work now about whether we can do something for a maintenance and maybe going from the injectables to an oral medicine or decreasing the frequency of dosing. And so there's been a lot of talk about what we can do in the maintenance phase. So this was from one of my review articles that putting both the cardiovascular outcomes and the weight loss, comparing the different GLP-1s and the dual agonists. For when I published this, we didn't have the SELECT trial results yet. So the MACE, the cardiovascular outcome reduction, major adverse cardiovascular outcome data, was only from trials that included patients with type 2 diabetes. So keeping that in mind. About liraglutide confers about a 6% weight loss, and this is also dosed by sub-Q injection daily. So, we don't really use it that much because you have to dose it daily, and it also is less effective for weight loss. But in the LEADER trial that enrolled high-risk patients with diabetes, it did confer a 13% reduction in major cardiovascular events. So it did reduce vascular events. Semaglutide, again, dosed a weekly, a sub-Q is much more potent, that 12% weight loss. The SUSTAIN-6 was the large cardiovascular outcome trial, again, in persons with diabetes. And with more significant weight loss, we see that there's was a 26% reduction in major cardiovascular events in SUSTAIN trials. So really significant cardiovascular event reduction. This is why in persons with diabetes, these are cardiovascular prevention drugs that, sometimes have greater benefit than we even see with lipid lowering therapy like PCSK9 inhibitors. Tirzepatide, as I mentioned, has a 17% reduction in weight. We don't have a cardiovascular outcome trial yet with tirzepatide. There's at least two ongoing. SURPASS is evaluating persons with type 2 diabetes, looking for cardiovascular outcomes. And then SURMOUNT MMO is enrolling patients with overweight and obesity, evaluating cardiovascular outcomes. So that hopefully should be forthcoming. Dulaglutide did not have a weight loss trial, but was studied in persons with type 2 diabetes for cardiovascular outcomes. And one thing with REWIND is that 2/3 of the patients had diabetes, but primary prevention without established cardiovascular disease. So it was largely a primary prevention trial, and we see a 12% reduction in major adverse cardiovascular events in that trial. So in terms of the current FDA labels, the current FDA labels for overweight, and obesity management are just liraglutide and semaglutide. I anticipate before the end of the year, tirzepatide will be on this list after SURMOUNT. They already submitted to the FDA and it's fast-tracked. In terms of MACE reduction, currently it's only liraglutide, semaglutide, and dulaglutide in persons with type 2 diabetes. But after SELECT fully publishes out, I anticipate they'll try to achieve a MACE reduction indication for semaglutide in persons without diabetes, but overweight and obesity. So just a reminder why these are cardiovascular prevention drugs, and we should be using them in our patients with type 2 diabetes, that in meta-analysis, we see these are all persons with diabetes, but that GLP-1s conferred a 14% reduction in major adverse cardiovascular events, a 13% reduction in cardiovascular death, 10% reduction in MI, a 17% reduction in stroke. We don't see these stroke reductions, with even SGLT2 inhibitors. There was some heart failure reduction in the meta-analysis, likely from their weight loss effects. And there seems to be some favorable trends in kidney function, but there was mostly driven by albuminuria, but we're waiting for the dedicated kidney outcome trial FLOW. So while we're waiting for SELECT to officially publish out, there was a meta-analysis that looked at the weight loss trials and looked for cardiovascular events as part of a safety analysis. So, the STEP trials were with semaglutide and the SCALE trials were with liraglutide. And aggregated together, again, these were cardiovascular events were collected as safety endpoints, but we did see a 19% reduction or fewer cardiovascular events with the GLP-1 treated patients. So this, of course, is not the same as a dedicated cardiovascular outcome trial, but really is more supportive evidence of the benefit on meaningful cardiovascular outcomes with GLP-1 therapy in persons with overweight and obesity, but without diabetes. So the trial we're all waiting for, and we've had a preview of some of the results, is the SELECT trial. So this was the cardiovascular outcome trial with semaglutide in persons with overweight and obesity, but no diabetes, who were at high cardiovascular risk. So enrolled patients who had a BMI above 27, but they had to have established cardiovascular disease. So it was a secondary prevention trial. Patients were randomized to semaglutide or placebo, and they're titrated up to get to goal. They're titrating their placebo or titrating up semaglutide to a target of 2.4 milligrams subcutaneous per week. And it was an event-driven trial, and it ended when they achieved enough, they're powered for events. So the official trial has not been published yet. It's going to anticipated presented at the American Heart Association meeting. So it might be an exciting November, but the company already released a top line statement in August that semaglutide reduced the risk of major adverse cardiovascular events by 20% in adults with overweight and obesity in the SELECT trial. And this was a 3-point MACE, cardiovascular death, MI, or stroke. And they said that all 3 components were reduced with semaglutide. Ultimately, they had 1,270 MACE events, and they said in their statement that semaglutide appeared to have safe and have the same well-tolerated profile in line with other trials. And we'll talk about the GI side effects and how to manage them in a minute, but those have been seen over consistently. So this is really exciting. A 20% reduction in cardiovascular outcomes. I mean, this is huge. I mean, keep in mind, and I use a lot of PCSK9 inhibitors, but we see like a 15% reduction with them. I mean, this is really meaningful cardiovascular outcome reduction. So this is very exciting. Also, at the end of August at the ESC meeting in Amsterdam, the results of STEP-HFpEF was presented and then published in the New England Journal of Medicine. This enrolled about 500 patients who had a BMI above 30 and had heart failure with preserved ejection fraction defined as an EF above 45%. The average BMI was 37 in the trial, so that was the average. So they had significant overweight and obesity in this trial, and 66% had a BMI above 35, so class 2 or 3 obesity. And what they showed, semaglutide subcutaneous compared to placebo had an 8-point difference in their Kansas City quality of life scores, and they achieved 11% weight loss, which is pretty similar to other semaglutide trials. Again, it was like 12% in the STEP trials. So those were the co-primary endpoints. It was not powered for hard outcomes, but they did show an exploratory analysis that, over the trial, which was only, 1 year, that only 1 patient in the semaglutide arm had a, heart failure hospitalization compared to 12 in the placebo arm. So that was a significantly fewer events. So again, that's not a cardiovascular outcome powered analysis, but again, more reassuring data that if you can meaningfully reduce weight in these high-risk patients, you can improve cardiovascular outcomes. And this is just the beginning. There's so many things in the pipeline, and I'm going to talk about some of them that are farthest along, but this is just the tip of the iceberg. First of all, let's go back to oral semaglutide. So you may be familiar that there is an oral semaglutide with a indication for type 2 diabetes management, goes by Rybelsus, and at least in the original Pioneers trial, it wasn't powered for cardiovascular outcomes, which is why we prefer the injectable. But the issue with the oral semaglutide, at least in the diabetes dose, at 14 milligrams, is that these when you give it orally, these peptides, they're rapidly a lot of it's rapidly degraded, and so it's less effective when you give it orally. So they try to overcome this by using a much higher dose. So the OASIS trials looked at 50 milligrams daily of semaglutide. So that's compared to the 14 milligrams that we use for diabetes. And this was just published in the Lancet this summer and showed that, oral sema in persons with overweight and obesity, but without diabetes, reduced weight by 13%. And so this is in the range, the same range as we saw with injectable semaglutide, 2.4 milligrams once a week with the STEP trial. So with an oral formulation of semaglutide achieving similar weight loss. And so that's exciting because patients may prefer an oral option as opposed to injectable option. And we see that 85% achieved a weight reduction of at least 5%. Of course, one of the issues with all these trials is that people have side effects and some of them discontinue. So there's the, intention to treat analysis, and then there's as treated. And for those that actually stayed on their oral sema, they actually saw a greater weight loss, 17%. Now, oral semaglutide, at least in the diabetes dose of 14 milligrams, is being reassessed in a cardiovascular outcome trial because Pioneer wasn't powered for cardiovascular outcomes. So the SOUL trial it's rolling nearly 10,000 individuals who have type 2 diabetes and are high risk, established cardiovascular disease, comparing oral sema 14 versus placebo. And this is an event-driven trial. So we'll see whether oral sema can reduce cardiovascular outcomes. And so maybe that could get a MACE indication as well, similar to the injectable sema. Now, there's even other therapies that are being explored. So for orforglipron, this is a new oral agent, and it is a GLP-1 receptor agonist, but it's not a peptide. So it doesn't have the same sort of issues with degradation. And so they explored orforglipron in this phase 2 trial. It was published in the New England Journal of Medicine over the summer. Patients with overweight and obesity, had a comorbidity but no diabetes, and it's dosed orally once daily. And they also saw a 12% reduction in weight. So again, the same range as what we see with subcutaneous semaglutide with an oral agent. And it was, again, well tolerated. All these agents have GI side effects, but otherwise no safety signals. And again, similarly, where 80 to 90% achieved at least 5% weight loss with an oral medicine. Then there's triple agonists, so the next frontier. So there's retatrutide. So this is a molecule that's an agonist for not only GLP-1 and GIP, but also glucagon. So it's a single molecule that's an agonist of all of these three receptors. It is subcutaneous once a week, but they showed a 22% reduction in weight. So just as a reminder, we saw 12% with sub-Q sema. We saw 18% placebo corrected with tirzepatide, the dual agonist, and now this is 22% with a triple agonist. So again, we're just really getting close to bariatric surgery here, and again, exciting that we see more potent weight loss. There's also CagriSema. So this is a combination of cagrilintide that is an amylin analog. So amylin is a pancreatic hormone that leads in terms of gastric mobility, and also works in the brain in terms of regulating food choices and preferences and satiety. With semaglutide, and this combination of the two agents was also seen to have about a 17% weight change at 20 weeks. And this was, so this is exciting, kind of similar to tirzepatide. And there is a cardiovascular outcome trial in progress for that too, called REDEFINE 3. All right, so the challenge is that, these are not a magic bullet. And the biggest thing to deal with is GI side effects. It's important that we counsel patients on this. About 75% will have GI side effects, so the vast majority. Often it's mostly mild to moderate, like nausea, and it usually is when you first start and when you make a dose adjustment, but usually people become tolerant and the side effects get better. Often patients need to kind of make adjustments in their diet. That's the real main issue. And I'll talk about how we counsel patients about the GI side effects. We haven't really seen any other major concerns. In animal models, when you give rodents, GLP-1, there was an increased risk of medullary thyroid cancer. And so it's contraindicated in patients who have that history, but this has actually not been shown in humans yet. There hasn't been any signal, despite all these trials, of medullary thyroid cancer in humans taking GLP-1s. And keep in mind that liraglutide and semaglutide have been around since at least 2016 after the leader trial. So we've been using them for a while. And actually, medullary thyroid cancer is actually pretty rare in humans. It's actually papillary thyroid cancer is the most common, followed by follicular. So I haven't ever really seen a patient that had medullary thyroid cancer. I guess there was less than 1,000 cases over a 15-year period in the whole entire United States. But that, keeping that in mind, and you also avoid it in patients that have endocrine syndromes like MENS. So how do we counsel patients if they do have side effects? Well, nausea, there's the usual tricks we tell people with nausea. They can, eat crackers, apples, ginger-based drinks 30 minutes after the GLP-1, avoiding strong smells. Rarely people have vomiting, and this can be a concern if this is a persistent, but generous hydration, and really having smaller meals. There's decreased gastric mobility, gastric emptying. So that's why they feel full and eat less. But if they have a really large meal, all that's going to be sitting in their stomach. And so having smaller meals more frequently. If they're having diarrhea, avoiding, things that are carb dumping, like sports drinks, and other things that may contribute to diarrhea, making sure they stay well hydrated, having things like, chicken broth and other foods like that. If they're constipated, increasing fiber in their diet, increasing physical activity, again, hydration if they're constipated. For patients that have nausea or vomiting, one sometimes trick is telling them not to have fluids with their meal at the time of the meal, because they have food, and then liquids also take up a lot of volume in the stomach, so there's just a lot sitting in the stomach. So they can have their liquid, their beverage, 30 to 60 minutes before lunch, and then have their meal alone without liquids, and then they can have liquids 30 to 60 minutes after. So they stay well hydrated, they're just not having all that volume in their stomach at the same time. Obviously, if they have really severe refractory symptoms, they need to stop the medication and contact their healthcare professional. But it's important that we talk to patients so they have realistic expectations about side effects, and also about, what would be expected weight loss. And to avoid the side effects, we start out slow. With semaglutide, you start out, 0.25 milligrams per week. You do that for 4 weeks, then you go to 0.5 milligrams per week for a month. And then if they tolerate that, you go to 1, and then you go to 1.7, and then you go to 2.4. So it can take 5 to 6 months to get up to the maximal dose. And patients also need to understand we really don't see the significant weight loss till we get to these higher doses. We start with the lower doses for tolerance. So patients shouldn't expect, if they're only on 0.25 or 0.5, to see much weight loss at that point. It's really to get them used to the medicine. We really don't see much until we get to 1 milligram. With semaglutide, the target doses are 1.7 to 2.4. But, I honestly, in my practice, I just keep them on the lowest dose that achieves their weight loss goals. If we achieve their goal weight, then I don't feel the need to escalate them if they were able to achieve their weight goals at a lower dose. So involving patients in the decision making, how much weight loss is desired based on their cardiometabolic profile, following regulatory guidance. It's a question about whether all patients need the most potent medications. Some patients, may do well on some of the older anti-obesity medicines. But, as a cardiologist, I tend to want to use the ones that have cardiovascular outcome benefit. So in summary, obesity is associated with increased risk of cardiovascular disease and cardiovascular mortality. It's a chronic, serious, life-threatening disease, but we have treatments and we can help our patients. And to do this in a non-stigmatizing, fashion that we would do to address any other chronic disease, that we really, as cardiologists, should be considering them as treatment options. Certainly in our patients with type 2 diabetes, they should already be thinking about them. There's clear cardiovascular benefit for those, but also now in obesity, based on the SELECT data, and once we review the full trial results, this is not a cosmetic issue this is something that actually reduces cardiovascular events. And then, patients often, once they lose weight, they're actually even get more remotivated to even double down on their lifestyle efforts. Why lifestyle is always the first line, it's often not effective enough on its own for many patients, but the combination of lifestyle changes with pharmacotherapy. And then we talked about how to, with the GI side effects, with initiation and dose escalation, but otherwise the safety looks pretty good. But the biggest challenge is the financial barrier. So these medicines, many insurances don't cover them for the weight loss indication. I'm often really excited when they have diabetes, because it's easier for me to get Ozempic approved than Wegovy, even though they're both exactly semaglutide. So that's really frustrating. And I'm really hoping that the SELECT trial will change things, because that has, cardiovascular outcome reduction even in persons without diabetes. And I think that hopefully might change the landscape for payers, because it's really short-sighted to not pay, the upfront costs for these medications when you think about the downstream costs of all of the, morbidity that comes from obesity, from heart failure, from knee replacements, and so forth. So hopefully the barriers will get better, but I cite the guidelines, I cite the data. I'm always filling out pre-auths, and I have some standardized template letters that I use, and sometimes it works and sometimes it doesn't, depending on their insurance. So I'm happy now to take questions, and thanks again for inviting me.
Thank you, Dr. Michos, for the tour de force review of a really evolving and dynamic landscape. The chat was quite active, and I know that there are a lot of questions. So I'd like to give the floor to one of my co-fellows, Dr. Anjali Tucker, who has a good question about the implementation side of things.
Hi, Dr.
Yeah.
Michos.
Hi.
Yeah, go ahead.
Yeah.
You read it,
go ahead.
but I'm just so excited to get to meet you. I listened to some of your podcasts on lipidology, so thank you for teaching me a lot.
Yeah, and I think they roped me into coming back to talk to your fellows on lipids. You might hear from me again on lipids another time. But yeah, I didn't get to read your comment in the chat, so why don't you ask your question?
Oh, sure. Yeah, you sort of touched a little bit on lifestyle factors, but I can imagine a world, particularly in the US, where we get really excited about these drugs and they're sort of a magic bullet. Of course, I've met some patients who are like, nope, we've tried everything, it just doesn't work. So there's definitely those patients who are like intensively doing lifestyle changes. And then this is the next line, but I can imagine a world when these get adopted more, where, lifestyle changes can fade a little bit more to the background. So I'm wondering if you can comment on your thoughts on how do we best deliver these drugs? Is it coupled with digital therapeutics to help incent patients on these lifestyle changes? Is it creating obesity clinics that are sort of multimodal approaches? How do you envision this rolling out as it becomes easier to prescribe them?
Yeah, well, lifestyle is always the foundation, and I never, will prescribe these unless we've documented that we've really given a good trial for. And I'm lucky that I work with a nurse, practitioners that, or preventive cardiologist nurses, preventive nurses that have training and counseling, and so either they go to a registered dietitian or somebody else who can just do a separate visit just for the lifestyle piece, because often in our busy cardiology practice, we don't have enough time to really talk to them about that. So I send all my patients to our NP to have the whole lifestyle counseling piece, and we document everything they tried. And often some of the insurances require that they be in a weight management program. And for some of the insurances, they count Weight Watchers. So I encourage patients to enroll in that. And when I fill out my pre-auths, I document all that kind of things. Yes, we're really excited about whether digital apps can help. I mean, sometimes patients are excited about tracking things at first, and then that kind of wears off as the novelty. But we have a digital health center here at Hopkins, and some of my colleagues, like Dr. Seth Martin, are working on like the Corey app and other things that they can use to help see if we can combine it with digital health interventions. It's been my experience, though, that actually patients do better with lifestyle after they start these agents, because when they come to see me as a cardiologist, they've been dealing with this for years, often decades. This has been a long-standing problem, and they've tried everything, and they've been really frustrated. And people just tell them to eat less, and they're doing everything they can, and they just can't lose weight, and they feel like we're really dismissed. And so, but once they actually see the weight coming off, they start feeling better. Their joints feel better, they feel lighter, and they get more motivated about their exercise classes. So in my practice, patients have actually increased their lifestyle with these medicines. I do want to make a caution about, there's been a lot of exploitation, I think, or this whole like compounded field where people get these things at med spas and things. So I don't recommend any compounded medications. You don't know what's in there, what they're combining it with. They may be combining it with some high dose B vitamins that may have side effects, and maybe semaglutide salt. And so I just kind of steer away from compounded things, even though they can get it cheaper from these med spas. You don't know what they're taking. And also, so I only stick to the label indication. So when I prescribe semaglutide, I do the FDA criteria. They have to have a BMI above 30 and a BMI or above 27 with a weight-related comorbidity. I don't prescribe off-label. I have patients come and their BMIs are like 24, 23, but they want to, they've gained a few pounds, or they have the weight redisposition after menopause, the menopause middle that's so common, and they want beyond these agents. And I don't prescribe them off-label. I think we need to stick to, it's hard enough to get them for patients that meet the criteria that I personally will not prescribe them off-label. You'll see, hear about celebrities and people who don't meet the criteria, they're taking them. And I think that, does a disservice to the patients who really need them.
Okay, great. There are many more questions to get to. On that note of the role of kind of media, Dr. Goldschlager was actually asking about the role of market forces, media advertising on, the body image and having positive body image, at all weights. You mentioned your 5A approach. I wonder if you have any comments on, how we navigate that perspective for that part.
Let me just add to the question. I really need an honest opinion. A lot of this will not be politically correct, but all of us here and patients, we're the choir. And if you read the press and if you look at the movements and advertising and marketing, those are the people who really, the obesity epidemic is a national problem. It's not just medical. How do you get to them?
Yeah, I'm not sure I understand your question, but yes, it's so challenging in terms of, body image. So I don't try to get to everybody to the same BMI. So this is really tailored to personal goals based on their cardiometabolic profile. And people can be healthy at any weight. And so often it may be the BMI that their blood pressure is better, or they had remission of their diabetes or remission of their prediabetes. So not everybody needs to get down to, necessarily BMI less than 25. So I tailor their goals based on their patient and their risk profile. For better or worse, the media has done some good in terms of advertising these medicines to increasing awareness about them. But I also, think that also leads to some misinformation about this being some kind of cure or quick fix, and we know that it's not. But these are challenging issues, especially with the short supply, and that's why it's really comes down to shared decision making with patients, and not because of something they read online. So there's interesting groups. There's some groups out there that are adamant that we should never be using pharma and everybody should be doing just lifestyle. If you just exercise enough and diet enough, then everybody can get thin. And people comment on Twitter and things like that they think that that's enough for everybody. But no doubt lifestyle is so important as the foundation, but the people who are saying that often have never struggled with obesity or haven't had the same challenges. And genetics and the brain drive a lot of weight set points. And if it was as simple as just everybody just needs to diet, we wouldn't have 71% of the population being overweight and obese. And so it's just not that simple. And I think those messages that all they have that there should be no role for pharma, and it all should just be focusing on lifestyle. But clearly, it's better to prevent obesity than to treat it, because people get to a new weight set point and then they're stuck at the set point and they can't get back down. And so we need to start trying to, there's not enough, these medicines are too expensive and there's too many people at risk that we can't treat everybody with GLP-1. So we really need to shift a lot of things we do in society and work on primordial prevention, obesity prevention, starting in utero, focusing on, children and young adults, and not getting back to just making it all about individual choices, but making this with different policies and society and availability of fresh fruits and vegetables and food sources, and allowing time for exercise in the workday. And I mean, there's a lot of policy and societal changes that need to happen to overcome this huge epidemic. And so absolutely, GLP-1s are not going to be the fix for this crisis, but they can be, part of one aspect of the solution, but we really need to focus on upstream prevention of obesity.
Thank you. Perhaps just in the Being mindful of the time, we can have one more question. Dr. Lee, do you want to ask yours?
Oh yeah, sure. I'll be quick. Thank you, Dr. Michos, again for joining us for a fantastic talk. My question is around, maybe getting to the fact that at the end of the day, like it's very unclear how these medicines improve, sort of directly affect the heart. Do you see that the cardiovascular benefit pooled, across the different CBOT trials, the degree of benefit is proportional to the weight loss when you compare to other weight loss therapies like surgery, or is there something else on top of that?
Yeah, that's an excellent question. And it really remains to be seen whether the cardiovascular outcome reduction is all due to weight loss versus some other pleiotropic effects. So a lot of people proposed a lot of pleiotropic effects, but that hasn't really been proven per se. Because if you look at, for example, just a marker like CRP, so semaglutide lowers CRP, but it seems to lower CRP proportional weight loss. And if you look at things like, I showed you the sub-analysis of Look Ahead, which was a lifestyle intervention. If the few people that were able to achieve that really significant weight loss, they also had outcome reduction. And we see outcome reduction with bariatric surgery. So whether it's really all about weight, because if you lower weight, you can improve blood pressure and insulin resistance and all those intermediates. So is it all driven by weight loss, or is there other pleiotropic effects? And that is something that's debated, and I don't think people really have the answer yet, but hopefully sub-analyses of the SELECT trial might, get insight. So I hope, after the main trial is published, hopefully some secondary analysis can look at subgroups and see if we can, figure this out.
Great, thank you.
Okay, with that, I want to acknowledge that we're 5 minutes over time already. Thank you again, everyone, for joining, and thank you, Dr. Michos, for a wonderful talk.
Yes, thank you again for having me. Bye.